To conclude our discussion about the basic tools that we have as psychiatric nurses, we're going to talk about therapeutic communication in relationships, stress and anger management, and disaster management and grief. So, to start off with therapeutic relationships and therapeutic communication, there's differences between what makes a relationship between a nurse and a patient therapeutic versus non therapeutic. And the main purpose of having a therapeutic relationship is encouraging interactions that elicit meaning for that patient. It is a basic nursing skill. It is based on professionalism and respect, and it follows the basic nursing principles. So, in order to have a strong therapeutic relationship, you have to have good rapport with a patient, which means that the patient respects you, trusts you, that you're using therapeutic communication, and that there's interpersonal harmony between the nurse and the patient. It is the use of empathy, which is the ability to understand and experience the emotions that the patient is having during a particular session, and the use of empathetic linkages, which is directly communicating to that patient that you understand what they're experiencing. As far as those professional boundaries go, it's limiting that self disclosure or the information about yourself that can be distracting the patient from focusing on their own needs. It's dressing appropriately and behaving appropriately. A non therapeutic relationship between a patient and a nurse does not elicit healing or meaning, and it does often violate patient boundaries of privacy, confidentiality, respect, and all those other nursing values. A therapeutic relationship with a patient is also based on self awareness, which is understanding one's belief, thoughts, motivations, biases, limitations, and how they affect others. It is super, super important as nurses that we are self aware, both as ourselves, so that we know when we're reaching our limits, so that we know when we need to engage in self care or set boundaries for ourselves so that we don't get burnt out. It's also important as a nurse so that we treat our patients with respect and we don't let our prior experiences cloud our judgments or treatment of our patients. Self awareness is very important for the patient because it allows them to find that meaning and to be aware of where they need to grow and what they need to work on. It's super important that we have self awareness when working with coworkers because it can improve our interdisciplinary communication and our support for one another. And it's also important that we're self aware so that we can protect our relationships with our family and friends. If we're super stressed out from work and we don't have that self awareness, it can interfere with our relationships with others. So, when we talk about therapeutic communication, we need to understand the different communication types. There's verbal communication and nonverbal communication. Verbal communication is when there is a sender that sends a message that's received by one another. It's the use of words, it's the use of um, noise, and it's only about 3% of the communication that we use. Verbal communication is involved in self disclosure, and it also elicits a bunch of different communication techniques that we're going to talk about. There's also barriers to verbal communication, like speaking different languages, or if a patient's experiencing hallucinations, they may start to experience changes in their ability to communicate verbally as well. Nonverbal communication is about 97% of our communication, and it involves posture, personal boundaries, um, reception of how they're interpreting other people's nonverbal language, and it can be opened or closed. So, when we talk about communicating with different levels of illness, there's a lot of different tools that we can use. And what I mean by communicating with different levels of illness is talking about how a lot of psychiatric symptoms can impair communication. If someone's hallucinating and they're seeing or hearing things that aren't there, they may be distracted. They may not know if the nurse is real. They may not be able to differentiate the voices in their head from the voices that the nurses are using. There's with depression, a lot of times patients may have delayed thought processes, meaning it takes a little bit longer for them to understand and process their own thoughts and their responses to questions and the questions that are being asked with them. If someone is manic, they may not have the focus to understand verbal communication or they may misinterpret nonverbal communication. So there's a lot of communication barriers with psychiatric disorders that we have to be aware of. And one key way to help develop our communication skills and develop our ability to communicate with different levels of illness is through analyzing our interactions. The tool that we use for this is a process recording or a verbatim. And this is when we write down word for word the conversation and we analyze what the patient said. We look for symbolism in what they said. We're looking for any defense mechanisms that they may have used. And we're also analyzing our own responses in interview questions. And in that, we're looking at our own therapeutic communication techniques. We're looking to see if our interview was effective. And if it wasn't, we're formulating different ways we could have approached that communication or approached that situation. We're looking for different themes and topics. So a theme is the overreaching reason why you're talking about what you're talking about. And what you're talking about is the topic. So someone's topic may not necessarily be what the theme is. So if someone frequently talks about the times that they had as a child, it may not be the topic of childhood, but it may be indicated the greater theme of them missing their siblings or feeling socially isolated or wanting some type of resolution with that. During analyzing our own interactions, we can also identify any blocks to communication and try and understand how to overcome that. One major block to communication are defense mechanisms. So defense mechanisms are things that patients or individuals use to try and avoid dealing with something or talking about something. They are categorized into different clusters, with narcissistic defense mechanisms being projection, denial, or splitting. So projection is when you have a feeling or a thought that you project onto somebody else. So if I'm really anxious one day and I'm hanging out with a sibling, I may say to them, "Oh my gosh, why are you so anxious?" When really I'm the one that's anxious, but I'm projecting that feeling onto them. Denial is when you avoid something that is reality but may be painful. So we see this a lot when people have a substance abuse disorder. They may say, "I don't have a problem." Or if they have cancer, "No way, there's no way I have cancer." Splitting is when you look at everything as all good or all bad. So that's where there's no gray area for people. So it may be something like everyone hates me or everyone loves me. There's no medium there. Then we have our immature defense mechanisms, and these are things like blocking, which is a temporary inability to remember something, often that's very painful or traumatic. Regression, where you return to earlier stage of development. So the example provided here is when somebody has another child, their older child who has gone beyond potty training may start to wet themselves again. We have somatization, where psychiatric problems present as a physical symptom. So we see this a lot with children that may be anxious or have depression. They start to complain of headaches and stomach aches. Or we can have interojection, which is unconscious imitation. Then we have our anxiety-based defense mechanisms, and these are things like displacement. So emotions are shifted from one person to another. We can have repression, where someone consciously tries to forget something. We can have the isolation of affect, where somebody just doesn't have an emotional response to whatever the reality is. We can have intellectualization, where they try to reason through something to avoid dealing with it or feeling the emotions. We can have acting out, which is an emotional outburst. Rationalization, which is using excuses to justify one's behavior. We can have undoing, passive aggressive behaviors, disassociations, and then we have our mature defense mechanisms. And mature defense mechanisms are generally a little bit more productive for the patient, and that's why they're called mature. And so these are things like humor. Using humor can really help people process the reality a little bit better than some of the other defense mechanisms. There's sublimation, which is the unacceptable impulse into acceptable channels. So, for example, if somebody is really fascinated with fires, instead of going around and starting fires, they may become a firefighter so that they get that fix without using that tendency in a negative way. And then we have suppression, which is the conscious forgetting um, of something that really is more painful or distracting for us to remember. So then we can move on to that nurse patient relationship. And as I said, it's based in rapport, empathy, the use of empathetic linkages, and professionalism. There are different phases of a therapeutic relationship, with the first phase being the orientation phase. This phase starts right when the nurse and the patient first meet, and it ends when the problems to be examined are identified or when the patient's goals have been set. The most important aspect of this orientation phase is forming that trust and respect between the nurse and the patient. It starts with the first meeting. And so, in order to build that trust and rapport, we have to ensure patient confidentiality, and we have to be aware of any behaviors where the patient may be testing the relationship. And some of these behaviors are arriving late, possibly expressing anger or accusing the nurse, and minimizing larger problems and exaggerating smaller ones. So, in order to overcome some of these testing relationships and to build that trust and rapport, again, we really want to focus on the patient. We want to encourage them to feel safe and comfortable. We want to prevent any inappropriate interactions so that they feel more safe. We want to educate them and let them know what the process of the relationship and the treatment's going to be to reduce any anxiety. Once you move past that orientation phase, you move into the working phase. And as I mentioned, this starts with the identification of the problems of which the patient would like to work on. So during the working phase, the patient explores these problems, learns to use their coping skills, and finds healing with their issues. One major barrier to the working phase that we want to be aware of is the concept of transference and countertransference. So in transference, um, the patient projects their feelings or thoughts, or I'm sorry, yes, the patient projects their feelings and thoughts about something onto that nurse. So, for example, a nurse may remind the patient of their grandchild. So they may feel more comfortable and warm towards that nurse. They may be kinder to that nurse than other nurses. Countertransference is the opposite, where the nurse projects their feelings onto a patient. So, for example, if somebody has a father that was abusive and a patient reminds that nurse of their father, the nurse may treat that patient more poorly. So it's really important that we identify transference and countertransference. One, so that we are self aware and that we're not projecting those feelings and interfering with the patient's care because of our own biases, but also so that we can maximize care for that patient and set appropriate boundaries. There may be some situations where you can use transference to your benefit. So, for example, if you have a patient that's really resistive to treatment, but they really need treatment and they're not working well with one nurse, but they have taken very kindly to another nurse, you can use that transference to make sure that that patient is set with that nurse to encourage um, compliance with their care and treatment. Then we have the resolution phase, and this starts when the problems are resolved. During the resolution phase, the nurse's responsibility is to assist the patient in transitioning into either community care or another healthcare setting. So they should be connecting with that community resource and encouraging newly established behaviors in the patient. They can coordinate care and provide improved discharge education. One way to avoid upsetting the patient at this time is to make sure that we're starting discharge education from the very beginning, from that orientation phase. A lot of times, patients may become very upset when it's time to be discharged because they have formed support and relationships in the hospital that they might not have outside of the hospital, and they may really like the structure and the support that they receive there, and they may be scared to be discharged. So they may try and sabotage their discharge by expressing anger or re-raising problems that have already been resolved. So it's important that the nurse tries to help that patient transition effectively from inpatient care to the next setting so that they don't try and go back to those working issues. Just like a therapeutic relationship, we do see some behaviors in a non therapeutic relationship. So these occur when the nurse and the patient feel frustrated with each other. They have varying approaches that cause inconsistencies, and the patient is not able to find meaning. Um, During this time, the first phase is the patient will often grapple and struggle with the nurse. The patient may be late to meetings, they may be unfocused in conversation. The nurse may feel uncomfortable and be less friendly and more direct towards that patient, or they may try and shorten their interactions with that patient. Then they enter the second phase, which is the mutual withdrawal, where both the patient and the nurse pull back and avoid interactions due to the frustration of their relationships. The third phase is termination. And at this point, we've identified that the relationship is non therapeutic. So we can switch nurses or switch providers and attempt a more therapeutic setting for that patient. With deteriorating relationships between the nurse and the patient, we find that the nurse and the patient often avoid and ignore each other. The patient may withhold information and implement other barriers like those defense mechanisms to prevent the relationship from growing. And the patient is really going to struggle with it and try and make sense of why the relationship was unsuccessful. So, what are some strategies that we can use to ensure that we have that therapeutic relationship with the patient? One of them is motivational interviewing. So, motivational interviewing is a way to engage a patient's own decision making abilities. And it's based on 8 features, which is openness to collaborate with clients' expertise, providing accurate empathy and proficiency in counseling, providing recognition of key themes in conversation, eliciting and strengthening the patient's readiness to change, rolling with any resistance and making sure that we're staying focused on that patient and their needs, negotiating change, consolidating patients' commitment to change, and being flexible with our intervention and communication styles, again, to best meet those patients' needs. Other pieces of technology that we can use to strengthen our relationship with our patients is things like phone use, video conferencing. So, especially as we are experiencing this pandemic, we know the importance of telecommunication and telemedicine. It's really expanded access for a lot of people to see a counselor, to see a doctor. But we also know that there are some barriers to video conferencing. A patient may feel less of a connection. And so we want to be aware of that if we're practicing that as well. Internet use is another thing that can be a barrier or enhance our therapeutic communication. The way that it can be a barrier is patients might come across some misinformation. They may be resistant to interventions based on their mistrust and the misinformation that they found out there. But the benefit is it allows us to help our patients get a greater understanding of the resources available to them, and it can help improve their communication. Other therapeutic relationship strategies include the transitional relationship model and the transitional discharge model. These are going to be beneficial in that resolution phase of the relationship. And they are based on the work of Hildegard Pepelau, who said that healing occurs in relationships. So, the transitional relationship model is the way that we maintain therapeutic communication with the patient until they've been transferred to another provider. Once that patient has been transferred successfully to the next provider in the next stage of care, it's really important that we withdraw our interactions with that patient to only professional based and need based. It's inappropriate to give patients phone numbers or to keep in touch with them after they've been in your care. Another key aspect to the transitional relationship model is the use of trained peer support. So, what trained peer support is you identify patients that have had psychiatric disorders or psychiatric treatment that have found places of recovery and have had good outcomes of care, and you pair them with someone that's going through similar symptoms so that they can help encourage that patient that's getting treatment, they can offer advice, and they can help advocate for that patient. Transitional discharge model is very similar to the transitional relationship model. However, it's when we discharge a patient from the hospital to the community rather than from the hospital to an outpatient or partial setting. So now we can move on to stress and mental health in nursing. So, stress is a transactional process from a real or a perceived internal or external environmental demand that appears to be threatening or benign. So, in layman's terms, basically what this means is we experience stress, which is physical and psychological symptoms, whenever we feel that our goals or our safety is threatened. When our response to stress isn't effective in helping to cope with that stress, it can lead to psychiatric disorders, immune disorders, and physical disorders. And we call this diathesis. So, diathesis is the genetic predisposition to an illness. So, you have the genes for it, but stress is something that activates it. And with this stress, the genes start to go from a genotype to a phenotype, and you start to experience the symptoms of that disorder. Also, increased stress during childhood could lead to things like drug abuse, eating disorders, mood disorders, PTSD, depression, and suicide. So, it's really important that as nurses, we help to teach people how to effectively deal with stress. There are two different types of stress. One is positive and one is typically more negative. So, eustress is the positive stress, and it's stress that motivates us to complete tasks that will result in a decrease of stress. So, it helps to elicit coping. The example for this is if you're feeling stressed to pass an exam, you study to try and reduce that stress. Distress is a negative form of stress that prevents the individual from being able to be productive and to cope as they need to. So, for example, if someone has a long to do list and they look at it and they start to feel very overwhelmed and stressed, so they avoid looking at the list and they go to play video games instead. Then nothing gets done on that to do list and it just prolongs the feeling of stress. When we're assessing stress, we have to look at the person environment relationship. And this is the interaction between an individual and their environment. So, as an environment changes, stress can occur to an individual, even if that change is positive. So, things like moving into a new home or having a baby, while those may be very positive milestones in someone's life, it can cause stress because it's that change in the environment, and we know that as people, we have a relationship with our environment as well. So, the different components that contribute to stress are based on the individual components and the environmental components. So, individually, we know that goals that we have greater value in are more likely to cause us more stress. So, if somebody is working to get a degree and they don't really need the degree, they don't really care for the degree, they're just going to school because they have nothing else to do, which I don't know if that really applies to anyone. But if that's the case, they're going to be less stressed to make sure that they're successful in passing their courses than someone that is really passionate about their education and highly values their education and really needs that education advancement to improve their job and economic status and their satisfaction in their work. So, our values very much contribute to our experience of stress. Also, personality types determine how stress is perceived and handled. So, individuals with a type A personality tend to be competitive, aggressive, ambitious, impatient, alert, tense, and restless. So, they tend to have a more of a physical reaction to stress. They feel stress more, but they're also more motivated to use coping skills and to address that stress. Type B personalities are often more relaxed and easygoing, more easily satisfied and accepting. So they tend to feel less motivation because they feel less stress, but they do tend to use more of a problem solving approach to their problems, which is a more effective way in dealing with stress. Type C personalities have a lot of difficulty expressing emotion. They're often introverted, respectful, but conforming. They're often very compliant and eager to please, and they avoid conflict. So when they feel stress, they often feel depression and hopelessness. And then there's a D personality where people often feel distress, increased negative emotions, pessimism, and they hide their emotions because they often feel very stressed. Environmentally, we know that social network plays a big role in the experience of stress. So, the ideal network is something that is dense and interconnected. But we do know that the larger the social network is, the more support and resources are available to that individual to deal with the stress. Social support is very important to experiencing stress and feeling support in stressful times. Um, and it can really be helpful to have dynamic, positive social interactions so that you feel that emotional support from loved ones by feeling loved and cared for. It is also tangible to have strong social support because it gives you resources. It can be informational because it helps you view situations in a new light. It can enhance your health outcomes and reduce mortality rates. And it can also help to buffer stress and assist in behavior changes. We also want to look at the environmental demands and constraints when we look at someone's experience with stress. So, a demand is a psychological and physiological need, which is internal, or environmental factors, which is external, that pull on an individual's resources. So, they often interact with one another, and it can relate to things like behavior and role expectations, or how crime, noise, pollution, and crowding can affect that individual. Constraints are limitations that are personal and environmental factors that limit an individual's resources. So, this is more related to their values or beliefs or money. Then we have our cultural experiences. Expectations culturally based on gender, age, morals, and values can contribute to someone's experience of stress as well. And then employment status is another thing related to culture. So, having a regulating activity and schedule allows for socialization, provides meaning, and also helps to us to determine our values. And then lastly, there's life events. So, like I mentioned earlier, even if a change is good, the more frequent changes that happen, the greater chance you have of becoming sick. There is actually a questionnaire called the Holmes-Rahe Recent Life Changes questionnaire. And this tool was developed to help people identify the different factors in their life that have changed their environment or their individual status. And based on how many changes you've experienced recently, tells you how much of a risk you are for experiencing some type of distress or crisis. So now we can talk about appraisal. Appraisal is key in understanding what types of stress we need to respond to and which ones we can let go. So appraisal is the process of evaluating stressors, and it considers the demands and constraints and resources and how they balance with that individual's goals and beliefs. So there's two different ways that we appraise our goals. And the first phase is the primary appraisal. And this is when the person evaluates events occurring as a threat, harm, or challenge. So it's when they feel stress about something, they can look at what's causing that stress. So, for example, if someone is trying to have a baby, they may feel stress related to that. So then they look at what is this stress threatening? It's threatening the idea of having a family. So, is that goal relevant to having a family? Yes. Is the goal consistent with that individual's values and beliefs? And are they committed to completing that goal? If the answer to all those primary questions is yes, then you evaluate the outcomes. So you would look and say, what's the outcome if I continue to be stressed about this? Ultimately, if I stay committed to this goal, I could have a family, but I could also experience the stress of A, B, C, and D in the situation. And then that helps you weigh the benefit and the risk to make a decision to either cope with the stress or to change your goals and change your focus so you experience less stress in those situations. This is also based on our vulnerability to stress. So we know that as we view the outcome as more important or meaningful, our vulnerability to experiencing stress in that situation is also going to increase. So, what is the stress response? We do know that we have both a physical and an emotional response to stress. Physically, you can experience the flight or fight response. And this is a homeostatic process as our body attempts to resist change and hold bodily functions consistent so that we can be well coordinated and stable to escape a threat. During fight or flight, our pH, our blood sugar, our oxygen level, and our temperatures are threatened. And our hypothalamus and autonomic nervous system can be activated, which releases adrenaline, cortisol, and epinephrine. So during that time, we may see things like racing heart, high blood pressure. As our blood flows to support our vital organs like our lungs and our heart, we may see that our gastric functions relax. We may notice that a lot of the heat is more central to the body. We're going to have a lot more muscle tension. And the purpose of that bodily response is to try and help us escape any threats to our own physical safety. Other physical responses to stress is illness. So there is a syndrome called the general adaptation syndrome. And this is when cortisol is released from the pituitary gland, and it's how stress can lead to illness. So the first stage of the general adaptation syndrome is the alarm reaction. And this is when our body perceives a threat, so it reacts. We start to feel those physical symptoms of the flight or fight. In stage two, our body tries to resist that feeling because it's uncomfortable to have a racing heart and high blood pressure and muscle contraction. So we try to implement coping skills to establish homeostasis and help alleviate those symptoms of stress. If that's ineffective, then we enter stage three, which is exhaustion. Another aspect to the physical stress response is allostasis. So these are regulatory processes that try to maintain that homeostasis through adaptation. But if it's unsuccessful in reducing stress, then we have what's called an allostolic load. And this is the consequences of wear and tear on our body and our brain that leads to ill health related to the damages that cortisol brings to with stress. So, for example, if we have increased levels of cortisol, it can damage our brain tissue that can lead to depression. It can also suppress our immune system. It can lead to cardiovascular accidents and metabolic changes. So, this is an explanation for why a lot of individuals that live in poverty may have more mental health issues as well as physical health issues because they're experiencing a lot more stress than someone that's in a more comfortable and stable setting. So then our emotional response to stress is based on our emotions. So it's our psychological reaction that defines our mood. Our emotional response to stress can be negative. And this is often when there's a threat or delay in our goal accomplishment. And these are things like distress, fright, anxiety, guilt, shame. We can also have positive emotions with stress, which is when we're moving towards our goal, and it can be things like happiness, pride, relief, and love. We can have ambiguous emotions like empathy, sympathy, compassion, and contentment, which isn't necessarily negative or positive or a good feeling or a bad feeling. It's just kind of that ambiguous feeling. Or we can have non emotions, which are emotions that are too ambiguous to categorize. And these are things like awe, confidence, confusion, and excitement. So, how do we care for those that are stressed? First and foremost, we want to help them maintain that physical wellness. So, we're going to run labs, we're going to do a physical assessment and any diagnostic testing, and administer any medications that we need to help maintain that person's body functioning and help prevent the physical effects of stress. So, we may provide them with antibiotics or cardiac medications, pain medications, anti anxiety medications. We do know that substance abuse increases stress. So even though people may feel stressful trying to wean off of a substance, it's going to be important that we do help patients find a place of recovery so that they can ultimately reduce the effects of stress on their life. We can also encourage non-pharmacological interventions. And these are things like diet, exercise, and relaxation techniques. Coping skills are going to be the main way that we can help support decreased emotional symptoms. And coping is a deliberate, planned, and psychological effort to manage stress and demands. Coping skills are positive and they lead to adaptation and decreased stress, or they can be maladaptive. And maladaptive coping skills result in illness, diminished self concept, and poor social functioning. So these are things like smoking, drinking, drug use when someone's using it as a coping skill to decrease stress. There are also some coping skills that may be positive for some people, or it may be maladaptive for others. So, for example, exercise is a very, very positive coping skill, and it releases a lot of chemicals in your body that actually help to fight the wear and tear of stress. However, if someone has an eating disorder and they don't even have the caloric intake to maintain normal organ functioning, exercise can actually do much more harm to their body. And so for that individual, it may be considered a maladaptive coping skill. There are different ways that we can enact coping, and it can be problem focused or emotion focused. So, problem focused coping is where the person identifies the source of the distress, and if possible, they change it. This is going to be the most effective in the long term for reducing the effects of stress and the reoccurrence of stress. If we cannot identify the source of stress, or if we have no control over fixing the cause of that stress, then we engage in what's called emotion focused coping. And this is where you try to reduce the emotional symptoms of stress by reinterpreting the situation and using coping skills that can help reduce the experience. So, here's a list of mental, physical, emotional, and spiritual coping skills that you can use for your patient. And coping skills should be patient focused. It should be used to help that patient adapt to whatever is going on. It should improve their social function. And it should really be aimed to that patient specifically and what their needs are. So, with coping skills, you can be very flexible. And so, some examples for mental coping skills might be like reaching out for support, practicing non judgment, using positive daily readings, visualizing a stop sign, getting lost in a good book, talking to a friend, watching a movie, journaling, things like that, taking a hot bath or shower, deep breathing, walking in nature, listening to music. Crying is a great coping skill. Attending group therapy, meditating, singing, journaling, praying, being in nature, volunteering. There's so many coping skills that people can use. So, one thing that I want to talk about too is a lot of nurses often neglect to use coping skills themselves, and they neglect to really make sure that they're reducing symptoms of stress in themselves. And that can lead to nursing burnout. So, nursing burnout is the physical, mental, and emotional exhaustion that nurses can experience by providing care. So, whereas stress is having too much, like your heart is racing too fast, you're feeling like too much is going on, you're feeling too overwhelmed, burnout is not enough. It's beyond the point of stress where you've just given up, so you don't feel anything, you don't have the motivation, you don't have the coping. And it occurs in 4 stages. So the first stage is physical, mental, and emotional exhaustion. The second phase is shame and doubt. So the individual starts to feel shameful that they feel so emotionally exhausted that they don't care. And then after a while, they enter stage 3, which is cynicism and callousness. And at this point, they feel guilty about feeling guilty. So they start to be indifferent about their feelings. And they say, oh, well, it doesn't really matter. And then the last stage is a state of failure, helplessness, and crisis. And it can increase risk of um, depression, mental illness, substance abuse, suicide, and all that. So, symptoms of burnout is feeling empty, having decreased motivation, being disengaged in care, feeling hopelessness, a sense of failure or doubt, isolation, procrastination, being short tempered or frequently angry, experiencing depression, having appetite changes, either eating too much or not having much of an appetite, having decreased immune functioning, which can lead to increased illness, fatigue, muscle and headaches, cynicism, decreased satisfaction with one's job, relationships, in life, withdrawing from responsibility, and it can impact your ability to be effective at work and to provide effective patient care. So, from a personal level, nursing burnout can lead to poor health in nursing, decreased thinking ability, increased suicidal behaviors, decreased life expectancy, and decreased satisfaction. Socially, it can impact the nurse's relationships and lead to aggression. And as far as the impact that it has on the working environment, nurses that are burnt out are more likely to have patient errors. They're more likely to call in or lose their job. They have decreased work performance, and they're more likely to either be bullied in the workplace or engage in workplace conflicts. Nursing has the second highest burnout rates out of any field in the US, and 20% of nurses leave the nursing field within the first year due to this burnout. Burnout is most common in nursing homes, psychiatric settings, ICU settings, trauma settings, and ER settings. So it's really, really important that nurses engage in techniques to try and prevent the development of burnout. So, prevention strategies include taking a break from technology, turning off your phone for half an hour each day, reconnecting with nature, engaging in stress management techniques, whether it's journaling, yoga, meditation, prayer, exercise, using relaxation rituals, Setting healthy boundaries for yourself, saying, no, I'm not going to pick overtime this week because I can tell that I'm starting to feel stressed out. And making sure that you're using healthy eating, sleeping well, and exercising. Once you've reached a level of burnout, there are treatment options for you. You can engage in support groups and counseling. A lot of facilities will provide employee assistant programs for you where you can get free counseling at the workplace. Also, evaluating your goals and priorities and shifting those goals and priorities if they don't match what you're doing. Changing the setting in which you're working in. If a unit's not working out well for you, go to a different unit or a different setting. Nursing is a very, very, very flexible field. There's a lot that you can do with nursing. And if you get burnt out in one field, make a change. See if that helps. Take time off of work. Make sure that you're using your vacation time. A lot of psychiatric hospitals will actually mandate that you take your vacation times and they won't allow it to be rolled over or paid out because it's so important that you take time off to rest and relax and not let work control you. Also, trying to decrease your workload if possible and redefining your responsibilities if possible. So, similar to stress is the management of anger, aggression, and violence. So, anger is a strong and uncomfortable emotional response to something that is unwanted or incongruent with one's beliefs or rights. A lot of people think of anger as an emotion, and in a sense, it is an emotion, but ultimately, it's a response to an uncomfortable emotion. So, the person feels something is wrong and they feel the urge to take action. Maladaptive anger is anger that can be harmful to the individual by enacting that stress response. And so, maladaptive types of anger is excessively outwardly directed anger. And these are individuals that are known to fly off the handle, attack and blame others, yell, use profanity and names, and maybe use fist or other expressions of physical anger. Individuals that excessively outwardly direct their anger are often linked to having cardiovascular disease and increased risk for heart attacks. Suppressed anger is the opposite, and this is when people feel anxiety during anger, so they act like nothing is wrong. They withdraw, sulk, pout, and ruminate on it. And this can lead to a more prolonged and more intense anger response. Individuals that suppress their anger have increased risks of arthritis, cancer, pain, and hypertension. And then there's constructive anger expression. And this is when you identify that you're feeling anger and it allows you to effectively cope with that anger so that you don't excessively outwardly direct it or suppress it. And constructive anger expression is things like exercise, doing calming activities, calmly discussing the situation with a family or friend, approaching the person or problem that you're angry with and using I feel and I think statements. So these are non accusatory statements that allow you to state your feelings and provide an opportunity to move forward. So it's never effective when you're angry to go up to someone and just say why you're angry. You should always have a solution to the anger. So saying, I felt angry that you didn't invite me to the party. Or I felt lonely when I wasn't invited to the party because you want it to be non-judgmental. And because of that, I don't want it to hurt our relationship. So in the future, when you're having an event, can I please be included? Or something like that to provide a solution to the anger. We do know that culture very much influences our expression and experience of anger. So, in Western cultures, anger can be seen as sinful, dangerous, and destructive. And the purpose of anger is to contain, control, and deny. So, this promotes aggression in men and suppression in women. In Eastern cultures, anger is often disapproved in both um, genders. And in some cultures, they actually promote catharsis, which is a way to vent anger. We no longer recommend catharsis because we find that it can lead to overly outward expression of anger. And so, like I said, the main recommendation on how to cope with anger is to have clear, honest expression of anger and talking through the situation. So, other symptoms of anger is you can have outward anger, which is towards someone or something, or inwardly stiflingly directed anger. Anger can vary in frequency and intensity. There are different scales that we can measure anger by, and we can also measure if it's trait anger versus state anger, and we can measure the expression of it. We want to assess our patients for possibly having intermittent explosive disorder, which is reoccurring aggressive outbursts that can't be attributed to other conditions. So their anger is disproportionate to the event. It often develops in teen years and continues throughout that individual's life. So, how do we manage and treat maladaptive anger? First and foremost, we want to help them build healthy communication techniques to express anger healthily. We can prescribe anger management, and anger management is a type of therapy that teaches the individual to effectively modulate the physical arousal of anger, to alter any irrational thoughts that fuel anger, and to modify any maladaptive behaviors. Anger management is usually a weekly meeting for 4 to 10 weeks, and we cannot have someone that expresses their anger violently be included in anger management. And the reason for that is because anger management kind of helps people identify what makes them angry and feel that anger and process that anger. And if someone responds to anger violently, you don't want to put other people that are in that therapy at risk. We can also prescribe them CBT or cognitive behavioral therapy, and that helps them to avoid provocation, helps them to self monitor their anger, helps to monitor stimulus control, helps to build positive responses, and effective anger management and relaxation techniques. Also, milieu therapy is going to be very effective in helping to manage anger. If someone is angry, we can help decrease stimuli and any negative confrontations with peers by creating a relaxing, non judgmental environment. And if absolutely necessary, as a last resort, we can prescribe medications to help somebody calm down. When anger is not effectively treated, it can lead to aggression and violence. So, aggression is overt behavior intended to hurt, belittle, take revenge, or achieve domination and control verbally or physically. It is often impulsive, but it can be instrumental or premeditated. Violence is the next step up, and it's extreme aggression involving the use of strong force or weapons to inflict bodily harm on another person or to kill them, and it is more intense than aggression. There's a lot of theories as to why anger and aggression develops. Um, we do see that there tends to kind of be a genetic component to it. It can also be due to damage to the cerebral cortex, which is where our inhibition and judgment is. So, if people have a traumatic brain injury, they may be more impulsive and prone to anger reactions. We do know that testosterone increases anger and aggression. So, males are more likely to experience anger and aggression than females. Also, the social learning theory by Bandura, the modeling behaviors, says that we learn and develop our behaviors by watching others. So, if someone grows up in a home where patients respond to anger with violence or aggression, that may be what they see as the response to anger. So, then they tend to develop those behaviors as well. Um, so, when we are working with patients that are angry, we want to make sure that we're doing a thorough assessment of their anger response so that we can promote safety. So, first and foremost, we want to assess patient history because that's the greatest indicator of aggression and violence. If someone has been aggressive and violent before, they're likely to become aggressive and violent again, especially with the same triggers. So, we also want to assess for those triggers. We do know that there's a lot of increased risk factors on the inpatient psychiatric setting, like involuntary status, suspiciousness, impulsivity, agitation, lack of medication and treatment compliance, symptoms associated with schizophrenia, bipolar disorder, brain injuries, alcohol withdrawal, and ADHD, increase aggressive and violent behaviors. So we know that patients are a lot more at risk for becoming violent on an inpatient setting than in other settings. We do want to know how to assess the physical factors to increased aggression. So these individuals may start glaring or staring at someone. The tone and volume of their voice may change, either higher or lower. They may show signs of anxiety or mumbling. They may start pacing. They may also experience impaired communication, disorientation, or poor social interactions during time of anger. So the best way that we can promote safety is through a strong patient to nurse relationship, relying on that therapeutic and trusting relationship to decrease agitation and to de escalate that patient. Um, Aggression may be a call for help. So we want to identify that underlying emotion that's leading to the anger and treat what the real cause is. Is the patient scared? Are they feeling lonely? Are they feeling disorganized? If we can identify that and treat that, we can prevent them from becoming more angry. Also, empowerment decreases agitation. So, if a patient has a good, strong relationship with us and we can tell them and empower them to help calm them down, that's very effective. We can also engage in de escalation techniques, which are techniques to help calm the patient down. So, in de escalation, we want to use non threatening body language and speech. We want to respect personal boundaries. We always want to have an exit plan. So, you should always be in between the patient and the door or an escape, because if a patient does become angry, you don't want them to corner you or prevent you from getting yourself to safety. You should remove any jewelry or long hair that can be grabbed by a patient. You always want to validate the patient's feelings. You want to provide choices to the patients and interactions and still keep that de escalation patient centered. You want to make sure that you're at the same level as the patient. So if the patient is sitting, sit down. If the patient's standing, stand up. You want to keep your tone neutral. You don't want to agitate the patient by seeming like you're getting more angry or elevated. We know that it takes about 3 minutes to de escalate someone. So, if you've been trying to de escalate a patient for 3 minutes and the patient is not relieving any of their aggression or anger or violence, then it may be time to try a more restrictive measure and go towards those chemical restraints or removing them from the situation a little bit better. Um, After the patient has calmed down, we want to discuss what had happened. We want to discuss what increased their anger or their aggression. We want to know what the triggering symptoms were. We want to know what would most help the patient calm down so that if it happens again, we can help that patient calm down better. And then we can also use distraction or interrupting techniques. So we can have the patient count to 10, talk them through deep breathing techniques, provide them with different tasks, or remove the stimuli that's making them angry. Milieu therapy is another super, super important technique in reducing aggression in the environment. So people build off of others' energy. So if someone is feeling agitated or overwhelmed, it's going to make other patients feel agitated or overwhelmed. So we want to reduce stimuli in the environment, and we want to consider the environment from the patient's point of view and remove any triggers or poor interactions that are happening. We can also hold violence prevention community meetings. So these are attended by staff and patients to talk about boundaries, to talk about the environment. How can we change the environment to help patients feel more calm? We can talk about different prevention techniques that might help patients calm down when they become angry. If those techniques don't work, like I said, we can give a chemical restraint. So, a chemical restraint can be given by mouth, intermuscularly, or intravenously. And these are medications that help to sedate the patient. They're usually PRN medications or as needed, and it can be things like Thorazine or a B52, which is Benadryl, Haldol, and Ativan, or other types of antipsychotics or sedating medications. If the chemical restraint doesn't work, then we move to the most restrictive measure, which is physical restraints and seclusion. So we've talked about this before, but seclusion is where the patient is locked in a room and they're unable to get out and they're under constant um, supervision of staff. Restraints are when we can put them in 4 or 5 point restraints. In the psychiatric setting, we usually use leather restraints, and that's where we hold their ankles and their wrists down to a bed. Um, we can use CPI holds or other types of therapeutic holds. These are more often done with children, but there's ways to help calm a patient down that may be getting aggressive, how we can help walk them to a safe setting, how we can hold them if we have to give them a chemical restraint like an injection. Um, We can also provide one-to-one supervision to help identify those triggers early and help de-escalate a patient early. And then we can monitor for any danger when using physical restraints. So we know that when someone is in the position that they're in, when we put them in restraints, it can release catecholamine hyperstimulation, where their body releases a bunch of catecholamines and it can cause positional asphyxia, and the patient can actually suffocate or go into cardiac arrest. So we really need to make sure that we're doing the proper physical assessments when our patients are in restraints. And then lastly, how can we prevent assault towards nurses? Nurses can make sure that they know how to use self defense techniques that are approved and safe in the hospital setting. Um, we want to make sure that we intervene early and effectively through using close observation, de escalation skills, and restraints when necessary so that we can prevent harm not only to those patients and other patients, but also to ourselves. It's also important that as nurses, we learn self awareness so that we can effectively care for patients that may have hurt us as well. We do know that aggression towards staff has a lot of premeditated factors and a lot of risk factors. So, if we can eliminate those risk factors and educate nurses on how to identify early signs of violence, then we can help um, educate them on effective techniques to prevent that as well. Aggression towards staff can lead to physical violence towards staff, verbal abuse, as well as sexual violence. Um, so we may need to identify patients that are at risk for that. Ultimately, we want to make sure that we are providing support for nurses by having safe patient to staff ratios and that we have effective legal protection in place as well. So, lastly, we have crisis, grief, and disaster management. So, a crisis is a time limited event that is a perceived challenge or threat that overwhelms our capacity to cope effectively. Generally, a crisis lasts 4 to 6 weeks, and if an individual positively copes with the crisis, they experience growth, change, and strengthened coping skills. If they do not effectively cope with the stress crisis, it can lead to negative outcomes such as hopelessness, depression, and suicidal behaviors. There are different types of crises. There's developmental crises, which are events related to the process of maturing, such as going away to college, taking on adult responsibilities, completing school, and going through puberty. There's situational crises, which are specific stressful events like a breakup or a death. And then there's traumatic crises, which are unexpected or unusual events. And these can affect one individual or multiple individuals. And they're often related to things like violent crimes, natural disasters, or untimely and traumatic deaths. The experience of a crisis does occur in phases. So the first phase is when the problem occurs. Anxiety increases, and the individual tries to use coping skills to effectively respond to that crisis. Once the coping skills are ineffective, the patient enters phase two when they start to do trial and error coping skills. So their original coping skills haven't mattered, so they're just trying whatever they can to try and reduce the experience of the crisis. Then they enter phase three, where trial and error is ineffective and anxiety develops into panic. And so the autonomic relief responses occur, which leads to stage four, which is the crisis state. And this is when the panic becomes overwhelming and the personality becomes disorganized. And that's based on that general adaptation syndrome that we talked about earlier. There are two different types of crises. In addition to what we talked about. And one of those is grief, and that is the intense biological reaction to loss. Bereavement is the process of mourning and coping through grief, which is that type of crisis. There are different stages of grief and crisis, and this is dependent on what you use. So, the Kubler Ross stages of grief are denial, anger, depression, bargaining, and acceptance. And you do move back and forth between those different stages until you have reached that state of acceptance. There's also um, different stages to grief based on shock, which is denial and belief, acute mourning, which is the intense feeling, social withdrawal, and identification with the deceased or deceased person, and then the resolution phase, which is acceptance, awareness, and return to well being. So, the dual process model of coping and bereavement is how the individual's grief alternates between loss oriented grief and restoration oriented grief. So, loss oriented coping is the grief work, it's the intrusion of grief. So, you really feel the physical and emotional symptoms of the loss. It's breaking bonds, denying the grief, and avoiding it, and the individual becomes obsessed with the loss. Restoration oriented coping is where you address life changes and tasks to distract yourself from the grief. You can deny the grief, but you find new roles and relationships outside of your loss. The individual also becomes preoccupied with stresses caused by the loss. And ultimately, the individual oscillates between these two types of grief work until they reach that level of acceptance. So, now the different types of grief. You can have uncomplicated, traumatic, or complicated. So, uncomplicated grief is a normal response. The loss is painful and disruptive. Even though it's a normal response, grief is still an uncomfortable thing to experience. So, physically, they may have a lot of anxiety, crying, nausea, lack of appetite, and weakness. Emotionally, they may feel out of place with reality and isolate themselves, but they can still find meaning and purpose in life despite the loss. So their self esteem remains intact. The loss is often accepted without clinical intervention, and that uncomplicated grief typically resolves in that 4 to 6 week period. The task of experiencing this type of uncomplicated grief is symbolized by the tear analogy. So, this means that you accept the reality of the loss, you experience the pain, you adjust to the loss, and you invest in a new reality. Traumatic grief is more prolonged than normal. And we see this more often in situations where there's a sudden death, a violent death, a preventable death, multiple deaths, or a shocking death. And the individual experiences the normal reactions to grief, but also experiences shame, guilt, rejection, and self blame. So they still have that meaning and purpose in life, but they're starting to lose that self esteem. Women are more likely to express and confront their emotions than men. So men typically tend to experience traumatic grief more than women. Then we have complicated grief, and this is when the individual is frozen and stuck in a state of mourning. They develop all those symptoms of uncomplicated and traumatic grief, but they also start to feel denial, bitterness, and longing. They have trouble accepting the death or the loss. They have an inability to trust others, and they find life meaningless. They have no self esteem and they have become hopelessness. So, individuals that have complicated grief are high risk for suicide and homicide risk. So, what do we do for our patients that are experiencing grief? We can give them medications. Medications don't solve a crisis, they don't bring back a loss, but it may help take the edge off enough so that that individual can cope by reducing the emotional intensity through anxiolytics. We can use it to treat insomnia um, so that the patient can use effective coping skills. We want to help promote safety by monitoring for thoughts of suicide, self harm, or homicidal behaviors. If the loss has led to a change in access to shelter and food, we may need to assess their living situations and help them find stable living conditions. And we want to assess for substance abuse and any maladaptive coping behaviors. As far as the social network goes, we can help mobilize social support. We can refer them to telephone hotlines like suicide hotlines, crisis hotlines, and we can use therapeutic communications to help support that patient. As far as crisis service goes, we can provide them with short-term housing if they have lost their access to secure housing. We can help them through shelter protection or homeless resources. There's a lot of resources for individuals that have run away from home or have experienced abuse. And we can also refer them to different support groups and counseling. Um, Another thing that I want to mention is nurses can experience grief as well, especially following the death of a patient, after a patient assault, after experiencing patient self harm. And nurses oftentimes aren't given the time or resources to properly grieve because they'll say things like, oh, that's part of the job, or you have other patients to take care of, or you have time constraints. or you have to be strong for others. You can't be upset because that's not fair to the patient's family. But ultimately, we know that if nurses don't grieve properly, it can lead to burnout. It can lead to complicated grief in that nurse, and that can lead to so many negative effects for the patient, for the hospital organization, and for the nurse themselves. So, ways that we can decrease complicated grief in nurses is to have them provide postmortem care, to provide relaxation rooms and counseling for our nurses, having them take an hour after the death to just sit and decompress, encouraging journaling, trying to figure it out so that the nurse can take a day off or use some vacation time to cope and process with that grief. Other things that can lead to grief and crisis are things like disasters and terrorism. So, this is sudden, overwhelming, catastrophic events that cause great damage and destruction, mass casualties, human suffering, and require assistance from all resources. So, a disaster is something unintentional that causes all that, whereas terrorism is a premeditated and planned event that causes that great damage, destruction, mass casualties, and human suffering. There are different phases to a disaster. The first phase is the pre warning phase, and this is when the community prepares and potentially evacuates if needed. Then the event occurs. During the time of the disaster, we need to provide resources, physical assistance, and support, and we're focusing on encouraging survival. So we're looking at that biopsychosocial functioning, but mostly focusing on the physical. After the event occurs, you enter the third stage, which is the recuperative effort. And this is when we have healed all the sick and injured, and now we're starting to work on the psychosocial aspects of healing. So we're preventing long term complications of counseling. We're helping them rebuild, we're helping them repair any damage, and we're reconstructing the community. As you can see in this chart, there is a varying emotional response during different phases of the reaction. So during the pre disaster phase, people are feeling very emotionally heightened. Then the disaster occurs. As the disaster occurs, you see a spike in the emotions until you reach the honeymoon stage. And then as time goes on, you may start to experience emotional lows and disillusionment. And then we see another spike in emotions around the time of the anniversary. So it's important that we understand people's emotional response during the recuperative efforts as well, because people's emotions can impact the work that they're willing to do and the outcomes that they can have. One thing that we can do to help prevent some of the physical and emotional damage during a disaster is something called disaster planning. And this is a collaborative effort within communities where you pull all of your resources and you plan what you would do in the case of different disasters. So you may do mock disaster training. You may identify media awareness that you can release if a disaster occurs. You help to find flexible resources. So, a lot of times, like nursing schools will double as hospitals if the hospitals fill up too much. So, disaster planning is something that nurses can be involved in, and they can sit on a board and kind of help plan that as well. Common consequences that need to be addressed during disaster or terrorism is death, physical injury, increased PTSD, depression, and anxiety. And we need to take care of first responders because they're more likely to experience psychological stress from all that they've seen and all those that they've burnt themselves out with trying to help and help them recover. So, as far as interventions go for disaster management, biologically, we want to make sure that people have access to clean water, food, shelter, and medical care. Psychologically, we want to address any arousal, behavioral, or cognition issues, any feelings of survivor's guilt or bereavement. We need to provide safety, comfort, and consolation for individuals. We need to address any abnormal, irrational behaviors or cognitive distortions. So, we need to provide clear information and help people focus on reality. We can debrief with individuals and provide outreach. And we can educate the public on how to naturally recover. As far as social support goes during times of disaster, we have FEMA, which is the Federal Emergency Management Agency, and they review devastation after a disaster, provide counseling and mental health services and training programs. We also can refer patients to substance abuse and mental health services, as well as the Department of Health and Human Services to help assist victims and responders. So, that in a nutshell is all the different aspects of therapeutic communication, stress and grief, and how to best support and de escalate patients that are experiencing different types of emotional crisis.